Slides on. Good morning, everyone. I thank AIOS and the team of Ocular Oncology for giving me the opportunity to speak on my favorite topic on orbital retinoblastoma. And welcome to Dr. Munir, who has come all the way to be part of the keynote address and the conference in India. Welcome once again. So my topic is orbital retinoblastoma. As you all know, orbital retinoblastoma has a worse prognosis, and it is the advanced stage of retinoblastoma. So the most challenging situation in the management of retinoblastoma is definitely in tackling with cases with orbital retinoblastoma. Well, so most of the patients die due to the disease, so can we save them? I have no financial disclosures, and patient consent is taken for all photographs. I request you not to take pictures. This is the best scenario that I can think of. 2-month-old baby presenting really early, unilateral retinoblastoma, group D. Very easy. It's a pleasure to have such cases in our clinic, but then situations are not always the same. You also face with such patients with advanced diseases, especially in the developing countries where they come with very advanced disease like the tumor spreading into the orbit and beyond. So orbital retinoblastoma is the extraocular extension of an intraocular RB. It can be due to late diagnosis and advanced retinoblastoma, improper enucleation technique leading to secondary orbital retinoblastoma, lack of histopathological evaluation of the enucleated globe, and further management where the patient can again come back with orbital seeding and orbital retinoblastoma as a secondary, and intraocular surgeries without, in cases which is not known to have harboring retinoblastoma, can also lead to extraocular extension of an intraocular RB. Usually they present as unilateral, proptosis in the eye. They can be subtle proptosis. A patient presenting as subtle proptosis in this case should be evaluated radiologically to look for any extraocular extension, be it an optic nerve extension or an orbital extension. There is a progression. Initially, the patient may present with subtle proptosis, then it progresses to form a very evident proptosis and even bulging of the entire eye outside, leading to fungating masses. Radiologically, this particular case, he was a 2-year-old male baby, bilateral retinoblastoma. As you can see here, the white reflex in the right eye, a large fungating mass. So this is like really advanced. And here in the radiological MRI picture over here, you can see the entire orbit being filled with the tumor, prechiasmatic extension, and unfortunately this child had leptomeningeal disease, which was evidenced by CSF cytology. So we classified orbital retinoblastoma into primary, secondary, accidental, overt, and microscopic. What is primary? Any patient presenting primarily as an intraocular RB extending outside into the orbit. Secondary, where the child has already undergone an enucleation, and then there is an orbital recurrence of the retinoblastoma. Accidental, as in this case, where the child was diagnosed to have hyphema and traumatic vitreous hemorrhage, underwent vitrectomy, and finally, after 3 months, there was an extraocular extension of the tumor. Overt are those which goes undiagnosed or missed clinically, and then it is detected during enucleation. So this is an overt, which is again an optic nerve extension and an extrascleral extension of the tumor, which clinically got undiagnosed. And then we have the microscopic, where pathologically we have optic nerve extension up to transection, scleral extension, and extrascleral extension. So this is how we classified orbital retinoblastoma. Staging is very, very important. So we do bone marrow biopsy and CSF cytology in these patients in order to rule out whether there is metastatic disease at presentation with orbital retinoblastoma. So Dr. Nandan has already spoken about the classification. So orbital retinoblastoma falls under the stage 3 with overt orbital disease. They may also have regional lymph node metastasis. And once they have a metastatic disease, they actually become stage 4. So what is a global burden of orbital retinoblastoma? Well, there is a wide disparity between the West and the developing countries. As you can see, it's less than 2% in the developed world as in the West, but it ranges from 6 to 60% in the developing countries as shown in the figure. Alarmingly and unfortunately, 80% of the children in Africa presents with orbital retinoblastoma. India is not least. Again, there is a reported literature of 30% patients presenting with orbital retinoblastoma. So is in Pakistan, Nepal, and other neighboring countries of India. So we did evaluate the literature on the conventional management of orbital retinoblastoma. As you can see here, Kiratli et al. Conventionally did an exentration alone, and well, the mortality was accounted to be 100% in these patients. Radiotherapy alone again has a mortality rate of 100%. With a combination of radiation and adjuvant chemotherapy by Pratt et al., the mortality was 70%. 30% children survived. So our major concern was life salvage in these children. We needed chemoreduction. We wanted this large tumor to shrink down. We also needed a complete surgical clearance. Treat the microscopic surgical residual in the orbit so that it doesn't recur, and also try and prevent systemic micrometastasis, and thereby increase the life salvage in these children. So this particular protocol was put forward by Dr. Hunavar, and we worked on this during my fellowship with him. It is the intensive multimodal treatment protocol that we administer for these children with orbital retinoblastoma. How does it work? It starts with high-dose chemotherapy, the same protocol as vincristine, etoposide, and carboplatin as in any other retinoblastoma. We administer 3 to 6 cycles, and then we re-evaluate the child radiologically for complete radiological regression of the orbital component of the tumor. If we find that there is radiological regression, then the child undergoes enucleation. After that, external beam radiotherapy in the form of linear accelerator and stereotactic radiotherapy is administered, and then there is a completion of high-dose chemotherapy for 12 cycles. So why multimodal treatment protocol? As I told you, our concerns. Surgery alone, enucleating or exentrating alone, will not give you a complete surgical clearance. There can be microscopic surgical residual in the orbit. Systemic chemotherapy, yes, it treats the child systemically, but the residual orbital disease may not be taken care of. External beam therapy can treat the residual orbital disease. You can hit it with radiotherapy, but it's not going to take care of the systemic metastasis. And that is exactly why there is a combination of neoadjuvant chemotherapy, enucleation, surgical clearance, external beam radiotherapy to hit those microscopic surgical residual, and catering to the systemic micrometastasis by high-dose adjuvant chemotherapy. So we evaluated 40 patients, and these patients on presentation did not have systemic metastasis, either in the form of blood metastasis or CNS metastasis. So we had 18 primary cases, 2 were secondary, 10 were accidental, 2 were overt, and 10 was microscopic. So in our study, with the application of intensive multimodal treatment protocol, the survival was 90%. Kiratli et al. In 1998 also had applied multimodal treatment protocol. Well, this was also quite encouraging for us to go ahead with our study, with a 75% survival in those patients. So going on to a few examples over here. So this is a pre-treatment case, and this is after neoadjuvant chemotherapy, 3 cycles. As you can see here, the eye goes for phthisis bulbi. And exactly at this point, when the child reaches the stage of phthisis bulbi with radiological regression, is the time that the child undergoes enucleation. As you can see here, after one cycle, we could actually do a tarsography for the child. Similar in this case, phthisis bulbi, the child undergoes enucleation. This is a secondary retinoblastoma. As you can see here, there is an implant already placed there, a lot of tumor recurring in the orbit, and after 3 cycles of chemotherapy, it is almost regressed over here. Completion of 12 cycles, the implant is in place and the child is doing fine. This was another case that I would like to share where there is an extension of the optic nerve up to the apex. After 9 cycles of high-dose chemotherapy, complete regression of the optic nerve, extension of the intraocular RB, and the child is doing fine. This was the first child in our series, and he's absolutely doing fine. You can see how cosmetically also the child is rehabilitated. So survival in patients with orbital retinoblastoma improves with IMTP with a survival rate of 90%. Thank you very much. Thanks for your patient listening.
Thank you, Dr. Fairooz. Are there any questions, Dr. Fairooz?
This is very impressive, really.
Thank you, Dr. Mene.
I was wondering, you presented a case with involvement of the optic nerve that regressed following
Yes.
all the neotropic cycles, and then you remove the eye
Correct.
and the optic nerve, and it was the nerve was tumor-free.
Yes, the nerve was tumor-free. So we give the chemotherapy, and then there is a radiological assessment. So after 3 cycles, we radiologically assess, look for regression. If not, we continue the chemo for another 3 cycles. If not, for another 3 cycles. And then enucleate it when it's radiologically confirmed that the regression has happened. And then always, in any cases, we take a long optic nerve stump. So we might modify the enucleation technique, doing a little bit of, going more laterally and then taking out at the apex. The average optic nerve length that we usually take in retinoblastoma cases is around 20 to 22 millimeters. Yeah.
It was just, I had the information by that for invasion of the optic nerve, but not up to the chiasma, in the orbit, he was also giving intra-arterial
Okay.
because of the pharmacokinetics showing that there's a very high concentration of the drug in the
Yes. Yes.
and probably increasing the safety and to enucleate because there's a much better regression of the tumor.
Yes, so recently we just had a discussion with Dr. Honavar also. He might be able to comment on it. So there were these cases with, post-optic nerve involvement. After intraarterial chemotherapy, we see actually the regression in these patients. Yeah, Dr. Honavar, yeah, all right. Yeah. I agree, yes. That could be one of the application of intraarterial chemotherapy, even in orbital RP.
What stage that you usually, what stage of treatment ISCs are you planning? You can give it for it.
I was just commenting, Chantal's experience. So I think he had a patient with optic nerve involvement behind the prosa, obvious on the imaging, and gave as a neoadjuvant measure the intraarterial to have better regression and to operate in a safer way when you remove the eye and cut the tumor. After then you see that it's all systemic because you have to figure out that this patient is at risk, even though there is no cells, no tumor in the optic nerve following the inflation. You have to keep going.
Yeah, it causes actually quite a rapid regression, Dr. Seema, when compared to a systemic chemotherapy because the concentration of the chemotherapeutic agents are very high and you're directly injecting it. That doesn't mean that you're going to salvage the eye. You're always concerned about the life salvage. So it gives more rapid regression when compared to systemic chemotherapy, the intraarterial chemotherapy, even in orbital extension. Yeah. And then, well, of course, you give the systemic chemotherapy, takes care of the systemic micrometastasis, which is assumed, yeah. All right. Yes, please.
So in that case with the optic nerve,
Yes.
after 9 cycles you do enucleation.
Yes.
And if the
Yes, we did. So we don't breach the protocols until and unless it's like an accident. So EBRT has to be given. Okay, you know how much. So we actually plan the treatment depending upon the initial stage of the disease. We don't look at the stage when it's regressed, how the child presented. So that's the initial stage. So the planning of the treatment would have been already made. So we don't breach the protocols. But there are, even in our series, like those patients who are accidental retinoblastoma, like, you know, these were cases which were evaluated earlier. Now we give like a lot of intravitreal chemotherapy, etc. So those were, there were a few cases where FNAC was done, you know, a vitrectomy was done. So in those cases, certain scenarios, we have deviated the EBRT. Yeah, yeah. Very few cases in accidental. Otherwise, the protocol is, yeah, followed, yes. We don't breach it. So the staging is the first presentation of the child. Yeah.
There are no other further questions. Thanks, Dr. Fairooz.
Thank you, sir. Thank you very much.